I'm going to introduce Katerina Kucera, who comes to us from RTI. She's a PhD at the research director at the Newborn Screening and Genetics Laboratory at RTI. She's really been working very, very hard on this project, and we're very grateful. Her work focuses on translational research in human genetics, genomics, and epigenetics, and on implementation of new technologies for genetic testing. And she's leading the charge for the Newborn Screening Project in North Carolina, and we're going to hear a whole lot of work that they've been doing over the last year. So thank you. Oh, you don't need that.
Hello, everyone. And thank you for inviting me to speak about our early check program that we have in North Carolina and how we're planning to implement newborn screening for Angelman syndrome in the research environment. So newborn screening is a public health service to all newborns. Each of the states screen for about 32 to 35 different conditions currently. And adding another condition is quite an effort. And before that can be done, we need to collect a lot of data to really show that the screening is feasible and that it is appropriate and beneficial to the population. And to collect these data, of course, we need to do research, so we kind of caught in a classic catch-22 situation where screening cannot be mandated without the data, but screening has to be done in order to generate the data. And that's what early check is designed for, to answer these questions and pilot these newborn screening efforts. And so I just listed a few reasons why some of the conditions are not recommended for newborn screening. So for example, there may be no accurate or cost-effective screening test. And we have a solution for that, for Angelman syndrome. So May talked about an assay, and we are also using an assay that was developed a few years ago by our collaborator in Australia, and I'll tell you a little bit more about it in a minute. There might also be no proven treatment that must be provided early, but there are a lot of people in this room that are working on that. And third point here is that implementation of newborn screening might be too expensive or too difficult to do, and that's what early check is designed for. We test how it would work in the public health newborn screening environment. So the goals of the early check study are, number one, to offer infant screening under a voluntary research protocol to parents in North Carolina. Number two, evaluate outcomes of infants identified as screen positive. And we also study the impact on families and parents. And then, of course, the ultimate goal is to publish the data to inform public health policy and facilitate transition to standard newborn screening if it's appropriate. So early check offers a choice to the parents in North Carolina. So there are about 120,000 births per year, and we offer additional screening to all of the children that are born in North Carolina. So we send a letter inviting them for this additional screening, and they can sign up. And the study offers a variety of opportunities to generate data and evidence. So for example, we generate data to help determine population prevalence, detect early symptoms and onset, examine phenotype-genotype correlation, and also offer an opportunity to test pre-symptomatic treatments. So early check has been running for more than 4 years. We started in 2018 with 2 conditions, spinal muscular atrophy and Fragile X syndrome. So both of those conditions are now retired. We don't screen for them anymore. And North Carolina State, the public health system, now screens for spinal muscular atrophy, which we piloted previously. Currently, we are screening for Duchenne muscular dystrophy, so just one condition. We've been screening for Duchenne for 2 years now. And we are getting ready to add screening using sequencing. So that's something that Allison just mentioned, that's another strategy to pick up the children who don't have methylation changes. So the sequencing test that we'll be implementing will be testing for 3 different things. So a panel, something like 200 or more conditions that are actionable in early childhood. Then another panel for conditions that are a little bit less actionable in early childhood, and also genetic risk score for type 1 diabetes. So that's coming up next. And then we have several conditions in preparation. So chromosome 15 imprinting disorders, including Angelman, Prader-Willi, and DUP15q. We are very intensively working on the preparatory work for those conditions. And we're also considering screening for congenital cytomegalovirus and for a panel of lysosomal storage disorders. So Early Check is a large collaboration. It is led by RTI International. We are a nonprofit institute, research institute, but we work very closely with the North Carolina State Laboratory of Public Health and also the clinical centers around us. So Duke University, UNC Chapel Hill, and Wake Forest Medical Center. The projects are funded by a variety of public and private sources. So for example, the infrastructure of Early Check was initially funded by public funds, but the individual pilots for the individual conditions, we heavily rely on foundation funding and also pharma funding for these pilots. So Early Check, similarly to what May was talking about earlier, it's not just the screening, it's not just the lab test. It is an entire system that one has to test. So in the yellow boxes at the top, during the recruitment process, we provide a lot of education to the general public about the conditions that are on the panel and newborn screening in general. Then for those who sign up their newborns, we do the testing. Negative results are automatically reported through our web portal. Positive results are reported by a genetic counselor who also guides the family through the confirmatory testing and the follow-up activities through diagnosis. And we also offer participation in a registry and offer long-term follow-up services. As far as eligibility, moms can sign up their newborns prenatally and also postnatally up to 1 month of age. And once we receive the consents, this is all electronic, we match the consents to the demographic data of the dry blood spots that the state laboratory has. And we go retrieve the specimens and do this additional testing. So the families don't need to come to any other appointments, and we don't need to collect any other specimens to do this work. So here's a map of North Carolina and South Carolina with the yellow-orange dots showing where our study participants come from. So they do come from the entire state. And so far we have enrolled over 24,000 newborns and screened them for the conditions that are on the Early Check panel at the time when they enroll. So as far as newborn screening for Angelman, so we are working with David Godler in Australia, who developed an assay, also methylation-based, several years ago. And this assay has been tested on thousands of newborn dry blood spot specimens, but they were de-identified. And so this assay has never been used for prospective screening, which is what we do with Early Check. We screen, and then we report the results to the families and provide the follow-up services. So this is something that is unique to us. So we are not necessarily in assay development business. We are in assay implementation and really testing the newborn screening system. So a little bit more about the assay. So Angelman, Prader-Willi, and DUP15q syndromes are caused by genetic changes in the same locus. And methylation patterns in the promoter of this, an RPN gene, can be investigated to look at the signatures of imprinting. So the silencing of the genes is relevant in the brain, but the methylation is preserved. It's also present in the blood, which is really useful for newborn screening because we can use the dry blood spots that are currently collected by the newborn screening system. So again, it is really, we are halfway there. It is a really big part of it, that the collection of the specimens and actually bringing them all into the same laboratory from all of the newborns in the entire state. So we expect that the methylation will be 50% because one allele should be methylated and the other one shouldn't. And if there is a deviation from the 50% methylation toward 0%, that would be a signature of Angelman syndrome. If there is a deviation toward 100% methylation, that would be a signature of Prader-Willi. And an intermediate methylation would indicate DUP15Q or mosaicism. So we have the equipment, we have the staff, we have the expertise, we have the assay, and we're currently working on collecting patient specimens for assay validation, validating the assay in our CLIA laboratory, developing confirmatory testing and follow-up protocols, updating all of the early check materials to reflect screening for these conditions, and of course, updating the IRB and regulatory documentation. So all of this is needed before we can launch, before we can screen our first baby. Once we're there, we hope to screen for 2 to 4 years. So the pilot would take several years to complete. We will provide the screening, this is all free, screening, the follow-up services, and then evaluate the provisional screening algorithms as well as the follow-up algorithms to really optimize how this workflow works and to minimize false positive and false negative results. So as with many studies, it takes a lot of people to do this kind of work. This is the core group from RTI International, and on the left you can see all the expertise we need and we have in place to make this happen. So it's a great, passionate team that it's really dedicated to newborn screening work. And I want to thank to them, and I also want to thank you for your attention. And if you'd like to contact us, feel free to contact me or Ann Wheeler. She leads the follow-up part of Early Check. I lead the laboratory implementation, and we're happy to have a discussion with all of you. Thank you.